go through this quickly, then we're gonna go on to our next lecture. Gonna have a guest teaching us that one, so it'll be fun. And then if we still have time, I'll just keep going for us to keep moving, okay? So I wanted to clarify something because I misspoke and I need to fix any time that I misspeak. And it was the way that the slide was made, so let me go back to it. So this, and we were talking about propranolol. And propranolol was on the bottom of, so this is my slide 46, I think it's yours too, if I'm not mistaken. I think, is it 46 for y'all too? Okay, so everybody's slide 46. So cross out the one that was on the bottom of here. When I was trying to make the slides pretty, it did the duplicate of the propranolol. So your beta 1 is A through M, and your non-selective is N through Z. Okay? And then your propranolol is the one that we could also use when we're talking about like migraines. You'll see us using it for that as well, because of the lipophilicity across the blood-brain barrier. So that's the big things to remember about propranolol. But when I say A through M, that was just kind of to help you remember the names of which beta blockers are going to fall into which category. Now, when you're looking at this too, I'm not going to make up names. So you can either remember every single one, or just try to remember it how I just told you, like A through M, A through Z. Okay? Okay. All right, let me go back to where we were. Okay, we did that, we're here. Okay, so when we're talking about our treatment and understanding that we are going to individualize this based off of our patients, right? Everybody is gonna be different. Labs are gonna be different as well. So make sure that you're looking at your patient as a whole. Real life exam patient, we're examining them and what they need. Now, when I say that you can have a disease state and you're gonna develop your own toolbox, you're gonna find drugs that you love and you're gonna be like, I hate that one, I'm not gonna use it. And the next PA might be like, oh, I love that one. And inside you're gonna be like, you know? So you will see what you like. That is where you start, that's like your big umbrella, right? But it doesn't mean that it fits every single person, okay? So just be careful when it comes to that, like keep an open mind when it comes to new drugs. So if you're doing your labs and you see anyone who has albumin in their urine, you're going to try to put them on one of your ACEs or your ARBs. So albuminuria needs an A. They need an ACE or they need an ARB to take care of the albumin that's there. Now, you will see this in CKD and diabetes. Even if they don't have hypertension, we will put them on an ACE or an ARB to try to help protect their kidney, okay? So, if you see this, hypertension or no hypertension, anytime you see albumin, ACE or an ARB, okay? Especially with your CKD and your diabetes patients. Pregnant women, we already talked about them, right? Lifetime Movie Network, so labetalol, methadone, nifedipine are our 3 drugs that we're gonna use. If they're on a different med already, then we're gonna switch them to one of those 3, okay? Discontinue any of our other ones, switch them to our L, M, or an N. And then looking at this with our diabetic patients, just understand again, ACE or an ARB, if you see that albumin, pick any one of your medications that you have that's in your first line. So your ACE or your ARB, thiazide, we had our calcium channel blocker. Remember, your beta blocker is not one of the ones that has to be on there, okay? Beta blockers is not a first line med. Bless you. Okay, back to basics. What else do I want to tell you about? So when we're talking about our diabetic patients, remember, if you have them on a thiazide, that you need to make sure that they're checking their levels, because remember, your thiazides can make your glucose levels be altered, okay? So that normal insulin dose that they were typically taking may no longer work for them, right? You might have to increase, decrease, so just make sure that they're watching out for that. What other med that we talked about that could mess up our diabetic patients by masking their symptoms of hypoglycemia? Beta blockers, okay? So now those are your 2 drugs that you have that mess with your diabetic patients, remember those. Secondary stroke prevention. So this secondary is meaning, and when you hear prevention, right? Like I had a stroke, now what are you gonna do to make sure that you're protecting me from having another one? Like how can you protect this patient? So, big thing here, remember that you can put them on one of your first line meds. The only one that you can't use is going to be your calcium channel blocker, okay? So that's the exception. So that leaves you with your ACE or ARB or your thiazide for secondary stroke prevention, okay? I don't need you to remember the goal and all that stuff. I just need you to know what treatment options you have for someone if we're doing secondary stroke prevention, okay? So no calcium channel blocker here. Still our backbones that we have, okay? This is just basic things that we talk about and we can talk about with any drug, right? Any medication. Before you increase a dose, before you change a med, before you think that there's some type of resistance or a medication is not effective in that patient, make sure that they're adherent. Make sure that they're actually taking the medication. Did you pick it up? Are you taking it how it was prescribed? And don't ask closed-ended questions. Ask them the open-ended questions to make them like, tell me how you're taking this. Because if you tell them how they're taking it, they're just going to tell you yes. Are you taking this one today? Yes. No, you're not, right? So my mom had vitamin D. We'll talk about vitamin D. Typically, you take it once a week. She came and oh, my body is hurting me so bad. And I was like, oh, okay. And I was like, what did they give you? I know you went to the doctor, they gave you something. Oh, vitamin D. And I was like, oh, okay. And I asked her, I said, are you taking it once a week? And she said, yes. And I was like, but you just picked it up. And she was like, well, I've been taking it every day. Well, I just asked you, but it was my fault because of the way that I asked the question, right? We programmed, yes. So she was taking something every day that she was supposed to be taking once a week. It's right there on the label. You will have this happen all the time, right? So ask those questions first because it may not be something wrong with the med, it might be me, right? I could be doing it. So this is just saying, hey, check everything. We're talking about hypertension and like fluid overload, edema, things like that. See how much water they're drinking. We had a patient who was coming in and she's like, my doctor told me to drink 3 gallons of water a day. And she was like sneaking water in. We had her on a fluid restriction. And we were like, why is this lady not becoming dry? Like we couldn't dry her out. We were figuring out like what's going wrong. And her family was like sneaking in water. And so we went in, the pharmacy went in, we're talking to her. And she was like, well, my doctor said, and I was like, okay, well, the doctors here are telling you to stop so that we can get, like, and you don't need 3 gallons of water, ma'am. Like, you don't need 3 gallons of water. So you have to, like, take yourself out of all of the things that we're teaching you that is going to become common sense to you and be the lay person. Like, remember day one when you came in here, before you were a medic, before you were anything that had to do with medicine at all, and say like, all right, where was I? How did I potentially think? And I know some of y'all probably still not like that, right? But some people do this, okay? So hypertension, your big thing that you're always worried about and the thing that you have to remind your patients about is that fluid and them restricting themselves, especially if they're seeing that they're starting to retain more fluid. This will be very up and down, especially when we start talking about heart failure. This kind of ebbs and flows on how they're gonna retain fluid. And so in those periods where they're starting to see that they have that retention, water restriction. Salads, smoothies, everything that has water in it, you're trying to limit it during that time to kind of drive them and reset their body, okay? So that's all this is saying. Talk to your patients, get them to take their meds the right way before you just increase a dose. Okay, crisis versus emergency. Urgency versus emergency. What I want you to know when we're looking at this, lots of words, and I'm about to make it super simple because I really just want you to focus on the drugs because you're gonna learn a whole lot about the difference between the two. So when you look at urgency, think about it as like it is a crisis, right, that this person is in. They have hypertension, they're very elevated. But the difference between this hypertensive urgency and emergency is that there's no in-organ damage, okay? So urgency, there's no in-organ damage, they just have a very high blood pressure, okay? Most of the time, when people present like this, you see that systolic is over 180, is extremely high, okay? Sometimes you will catch this because someone is coming in and it's on accident, and other times they're like, oh my gosh, I just have this really bad headache, or like they're having some horrible symptom, and that's why they come in and you'll figure out that they're in an urgency, okay? So no in-organ damage. When you're talking about an emergency, in-organ damage. That's all I need you to remember, okay? So emergency, end organ damage. Urgency, they just have a very high blood pressure, okay? Over 180 for that systolic. So this is just going into more detail than I'm gonna ask you about, so we're not gonna look at this one. So FYI this one. Now, when we're looking at our urgency, okay? You're going to give them medication to help treat them. But the thing that you're trying to remember is that you don't want to correct it too fast. Remember how we were saying, like, if I've been riding here for a long time and then you just drop me, my body is going to be like, wait a minute, what's going on? Okay, so they have different things that you're going to see in guidelines, and I'm not going to focus a whole bunch on it, but I wanted to talk to you about the MAP, or the mean arterial pressure, which is that average pressure that they have in their arteries throughout one cycle, like one cardiac cycle. So their systole and their the systolic and the diastolic phase, okay? So it's their average pressure for that one beat, okay? So when we look at our map, you see that we're not wanting to reduce that more than 25% within the first 24 hours that they're in your care. Depending on the patient, depending on their ability to take care of themselves, they don't have to be admitted for you to take care of this. You can take care of this in an outpatient setting, okay? Depending on how you feel and if you trust that person or not, you can always admit a patient and we bill their insurance. But if you're in the military, you can, do what you want to do with people, which is crazy. Okay, so go get them back down, and then you start them back on their oral meds that they were on. That's another big difference when we're looking at urgency versus emergency, because we have a lot of our oral meds that are still gonna work. We typically will use our oral meds in these situations, okay? And then you figure out what their normal regimen was. Hey, like, were you taking this every day? Like, how did you end up in this urgent state, right? Because if I was on medications before, how did I end up with my blood pressure that high? Did I stop taking it? Did I run out of it? What happened? Okay, so you're gonna have to do the digging to figure out what happened. Now, let's say they said, yes, I've been taking my meds, I was taking them how I typically do, there was nothing stressful that happened in their life, right? Then you're worried about, okay, is this an optimal regimen for that patient? Did we ever get them under control? All right, but getting the background of what's going on is important, because you can start trying to change their regimen, and really what happened is, like, maybe their mom passed away or something. Like, you don't know. Somebody passed away that was very close to them, and now my blood pressure is like, right? So this happened to my stepmom. Her mother passed away, and then her blood pressure just went up, and they started to change her meds, and I was like, don't change her meds. Her mom just passed away, right? Like, this is why her blood pressure is high. She's grieving, let that go through. So we just, a couple extra doses throughout this time, and then everything is gonna start to fall back down, and guess what happened? Everything fell back down, her normal regimen was fine. So like I always tell you, meds are not always the answer to just throw at somebody or change their dose, change their regimen. Are they taking it? Is there anything going on? Blood pressure is reacting to stress as well, okay? So figure out stressors as well. So we're here. With this, I just wanted you to look at the fact that we're slowly lowering it, and that we can take oral medications in this situation. And when we're looking at our guidelines, they're not saying like one is better than the other. Like, just, you're gonna pick a med to lower their blood pressure. If it's one that is already in their regimen that they're used to, you can stick with that one and try to lower them down. Okay, your emergency, big thing I wanted you to look at here is that one that's in bold, that top bullet, right? This one, they're usually going to be admitted into the hospital because they have in-organ damage. Things are starting to shut down, okay? So we are gonna definitely be monitoring them. And then we're gonna use IV medications in these patients as well, okay? So that's where this kind of, your treatment for this is going to be a lot more aggressive, in the sense that we're trying to save whatever organs we can, so that we don't have multiple organs that end up shutting down on them. Because if that happens, you have a real big problem, okay? So, that's the difference between the two. No one drug of choice. You're gonna pick the drug based off of what the patient has going on. So look at the patient, hey, if they have asthma, I'm telling you about asthma, or if they have this, like, look at the basics that we learned about our drug classes, and then just pick one going from there, okay? So that's the difference between the two. No one drug of choice. You're gonna pick the drug based off of what the patient has going on. So look at the patient, hey, if they have asthma, I'm telling you about asthma, or if they have this, like, look at the basics that we learned about our drug classes, and then just pick one going from there, okay? And then this kind of gives you your options on what you're gonna use for those patients, okay? So in our hypertensive emergency situation, we're gonna go over some of these vasodilators because we haven't done that yet. But you had your ACE inhibitor, remember, everybody ended in Pril except for your enalapril because that was the only IV one, so you see that here. Your calcium channel blockers that you have, and then you have your beta blocker listed down there at the bottom that you can use. And again, these all come in IV formulations. Some of them also have oral formulations as well. So, emergency, I have in organ damage. Urgency, no in organ damage. I could potentially treat urgency outside of the hospital. My emergency, they're going to be inside of the hospital. And the way that you can remember that is because you have to do IV meds. And you can do IV, but you can't do IV meds at home typically, okay? And then just pick one of your meds depending on that patient's profile and what's going on with them to treat the emergency. All right, looking at your nitroglycerin, we'll talk about this again a couple of times when we're talking about it in the sense of our emergency. You see again IV, and what we're trying to do is make nitric oxide because as we know and we talked about a little bit earlier, nitric oxide is going to help cause some of that vasodilation, right? We're going to relax the smooth muscle and therefore we're going to drop the blood pressure, okay? So that's the big thing when we're looking at our mechanism of action for our nitroglyceride is again decreasing that that pressure that we have, and then it's also going to decrease the cardiac or the oxygen demand that we have on the heart at that time, okay? So multi-pronged effect, very good medication. Thing with this one is that it has a very, very short half-life, okay? So understand that this one is one of those ones where it's a quick wearing on, but it's a quick wear, it'll wear off pretty quickly as well. And then with this, hopefully you get your patient controlled within 24 hours because a lot of the time, what happens is they'll develop tolerance to this med and it doesn't become effective. So even when you think about like, if you're using it for over 24 hours, you'll see a decline in your response that you're getting from the patient as far as their blood pressure starting to drop. That's when you'll know, okay, they've developed tolerance to this, I need to switch to something else, okay? Your clinical use, acute decompensated heart failure, which we're gonna talk about in a little bit. Your hypertensive emergency, which is what we already have been talking about. And then if we're looking at decreasing that preload that a patient may have, then this is a good medication to help with that, especially in our patients who are gonna have a lot of fluid or pulmonary congestion around the heart, okay? And then adverse effects. So these, typically because they're not on them for a very long time, you don't see a lot of them, but if you're infusing too quickly, you're gonna be more likely to see some of these. But the headache is very common. That's one of the big things that people will see because remember, we're causing a lot of vasodilation. So think about a lot of blood now just being able to rush through everywhere in your body, essentially. So you have the severe headache, increased ICP or intracranial pressure, and vomiting. Some people will also experience flushing whenever you give them this medication as well, again, associated with the fact of how fast you would be running it. And then you see the I hate saying this word, methemoglobinemia. And with this, it's not something that's very common, but it is something that we can see that occurs. So just watching out for that. It's a fact that their hemoglobin essentially gets oxidized is what's happening with this. So a lot of issues with them having oxygen binding, essentially. So their oxygen being able to oxygenate their body is not as good as we would like to see. So you'll start to see this if you leave them on it for a very long period of time, or if they're on a very, very high dose of this medication. If you do see this happen, you can reverse it. There's an antidote, which is called methylene blue, and then that will reverse this side effect from happening in that patient if you see this happen, okay? Sodium nitroprusside, again, another one that is an IV medication. Any of these meds, so like let's say I were to ask you like which medication increases the formation of nitric oxide. You could say this one, you could also say what we just talked about, nitroglycerin, right? Because that is the mechanism of these drugs, right? So just kind of group them together. They're very similar to each other. Vasodilation still occurring in this one. Half-life is still short, like a lot of similarities when you're looking at your nitroglycerin and your nitroprusside. Clinical uses are also, again, very similar. So acute decompensated heart failure, we talked about, which is what we're talking about right now, your hypertensive emergency. This is one of the ones that is our drug of choice, like that we do like to choose. A lot less, the side effects aren't as serious sometimes, and it's a little bit more well tolerated, I guess. It's well tolerated compared to our nitroglycerin, but your nitroglycerin is one that we have that's readily available over this sometimes. So looking at your elimination of the medication, just make sure that you understand that it's renally excreted, and then your adverse effects, you have hypotension, you see you have the cyanide toxicity as well, and then the increase in the ICP, which we've seen already also, okay? So if I over vasodilate my patient, I'm gonna see hypotension, right? Because I opened up things too much and then I relaxed them too much. All right, nicardipine. This is not one of the first things that we would go to. You're probably gonna choose one of your nitroglycerin or your sodium nitroprusside before you would come to this. So out of these meds, I would kind of reserve this one as like, it's an option for you, but not a very common option that you would use. So this one is a DHP calcium channel blocker. And then when we're looking at it, you see that it is one of our meds that we can still use in several different clinical uses that we have for this. We'll talk about this medication a lot because we're gonna talk on and touch on a lot of these indications here. Available as IV, so that's why we're talking about it when we're looking at our hypertensive emergency situations. But again, we also have it as an oral formulation. And then long half-life compared to our other medications that we just talked about, right? Because we said both of our N's had short half-life, whereas this nicardipine N has a long half-life. And that's why we typically don't use it, because if I want to reverse something, and I'm working with something that's moving, right? It's a moving target, this blood pressure. So if I want to quickly change something, or if I see that I've overshot, if I have a long-acting drug, I'm stuck until that drug wears off. Whereas my short-acting ones, I can manipulate that a lot easier. I can change my dose as I need to. I can increase it and change it more readily and know that it's gonna be eliminated out of their system versus this one that's gonna hang around for a longer period of time. So when I correct them, I could possibly overcorrect them if my drug still has activity, okay? So that's why we don't see this one used as often. This half-life, I think, is like 14 hours. So depending on how long you're running this, that can be a couple of days for some patients by the time that it wears off. Enalaprilat. So again, IV medication, ACE inhibitor. We like this medication, good med. This is our only one that was going to be the IV. And then looking at our advantages, you see these here. We don't really like to titrate this often. We'll kind of run it for a short period of time and then turn it off. Avoiding your patients who have acute decompensated heart failure or if they've had an MI. We'll talk about that whenever we get to it, but essentially what can happen is like their symptoms kind of will become worse if we have them on this medication. So we'll go into that. Contraindications, we see this stenosis again, and then you have pregnancy, which is what we talked about in the very beginning when we talked about that drug class, right? So same contraindications are gonna apply. Esmolol, labetalol, again, mechanism of action, we've seen this, we talked about the beta blockers, right? So they're looking at them, giving you your mechanism, your clinical use, just making sure that you're paying attention to when you're avoiding things. A lot of these, you're gonna see where you're avoiding them in acute decompensated heart failure. Some of them you're gonna see where you're avoiding them post-MI in some of your patients. So pay attention to that while you're going through and you're studying this. If somebody has that severe airway disease, so something like asthma or if they have a lot of exacerbations, COPD, things like that, we're worried about those patients, right? Because we said this could affect that. What else? Looking at your esmolol and your onset, remember that this has the esterase that's playing a role in their metabolism. This is probably one of the first times that we've seen this or discussed esterase. So remember your esmolol, which is an E, has the esterase that is metabolizing it, okay? Your labetalol, again, you have all of these, most of these we discussed. The only thing in here that we haven't discussed is that you don't have that reflex bradycardia. So when you're looking at this, we'll prefer it in some patients who have like coronary artery disease, or if they have an aortic dissection, because I'm not increasing that cardiac demand, and we're worried about, especially if somebody has a dissection, making it worse, right? So that's why this medication will come into play and be a better option for us to choose that. And then again, doesn't reduce that blood flow. So dosing, I don't want you to worry about dosing. Just remember that you have IV formulation of this, and that if we have somebody who has an emergency, we can go and reach for this medication. This is a summary chart of what we talked about with the drugs that we can use when we're talking about our hypertensive emergencies, okay? So your drugs are on your left, letting you know kind of like what you're using, and it has your drug class, right? So vasodilators, which one are my vasodilators? Here they are listed. Remember, don't worry about that middle column, and then go over your adverse effect column over on the right-hand side, okay? So what are my toxicities that I'm worried about? What are my cautions that I'm worried about? So this just summarizes it. I like these tables better because it's less words, okay? Don't remember doses. I don't need you to remember any of these doses here. Looking at your ACE inhibitor, we said that what we preferred was our enalaprilat. And then again, you have your adverse effects on the left. Don't remember your middle column. Your narcolepine for your calcium channel blocker, and then your adrenergic inhibitors, or what we call beta blockers, are also listed down here. Again, just look at your adverse effect column and your drug column, okay? We're still talking about your agents that could be used in your hypertensive emergency. All right, so I'm gonna give you a little review really quick before we go on to the next one so that you have it. I also have uploaded so Colonel Sternberg makes like these one-page sheets, and I didn't change enough to where you cannot use the one-page sheet. So I've uploaded like a two-page review over this lecture. Now, can you use just that? Sure. Will 100% of your questions come from there? I will not promise you that, okay? So, I will go through the slides, and then I would kind of keep going back to the sheet to refresh myself, because I will never guarantee y'all that everything will come from any of my reviews, okay? All right, so I will post so that y'all aren't like taking pictures crazily and like trying to write all this down. I will post these at the end of today so that you have it, like a summary of it. So when we're looking at our first line medications, first one that we're going to talk about is our thiazides. What are a couple of things that you can tell me about some thiazides? Where do they work? All right. What else can you tell me about it? Okay. Retaining some potassium. Fluid.
Hypernatremia.
Right? Yeah. Messing up with my diabetes, right? I have diabetes. I'm worried about that. Okay. So what I did was I went through and I put some high notes, little quick snippets of things that we need to know about each of these classes so that you can kind of, all right, where am I going when I'm thinking about this med, right? So potassium, sodium, wasting, right? But I'm gonna increase or alter blood glucose levels, calcium, the uric acid. So remember my patients who had gout, whenever I'm talking about my contraindications, they have to have good renal flow, right? Because remember where it's working. Think about that with your mechanism of action. So I need to be over 30. And then if I have a sulfa allergy, and then with my serum creatinine, I just kind of put the number 30 in my head for a bad creatinine clearance. Usually on most of our drugs is the cutoff. And then when you see serum creatinine, most of the time, it's gonna be like, it'll say over 2 or 2.5, okay? So if you see any labs like that, it's like, hold up, I can't use this med, okay? Those are your contraindications, your sulfa allergy as well, all right? What's another one that we have, another drug class, right? We had our ACEs or our ARBs, right? One or the other. Remember with your ACE inhibitors, they all end in pril except for our enalapril. And then your ARBs all end in sartan, okay? And then we have all of our high notes, I listed them here again, right? So now just think about, we had wasting before with our thiazides, but with our ACE inhibitors, now we're increasing it, right? I'm taking it back, all right? So then just kind of think of the opposites of this is what I told y'all. So increase in potassium, serum creatinine, and our BUN. Remember, we're likely to see that initially within that first 2 to 4 weeks, where that's gonna increase. So that's why we're monitoring them. And we bring everybody back in that 30 days anyway, but if you're super concerned, we had that 2-week window where we can also start looking at our labs to say like, hey, are my drugs affecting them? Am I outside of that safe bump, or is it too high? Remember with our ACE inhibitor, we're more likely to see our cough and our angioedema, especially in your African American patients, okay? So that increase is gonna go up for those patients. If you see that, then you can switch them to an ARB. It doesn't make you have to start with an ARB or make you start with a thiazide or a calcium channel blocker. That's old thinking. Now you can start them with whatever med you want to start with, and then if they have a reaction or if you're not seeing improvement, then you add on medications, then you start switching medications, okay? Your contraindication makes sense, right? Because I am potassium sparing, go ahead.
Would it be good to just start somebody on both the thiazide and an ACE or ARB to
I'm gonna talk to you about that, but yes, you could do that.
eliminate the risk of
You could do that, but if I'm only stage 1 and you diagnose me with something and now you're giving me this combo, you could potentially you could lower their blood pressure too much because they're only stage 1. So could you do it? You could do it. It just depends on how your patient responds to it. But remember, your stage 1 would only need 1 drug. So yes, you would be combating the two, but you could also drop them 2 up. So that's your risk. But yes, you can do it. And that is why we typically see those paired together. Yeah. Also, so with your contraindication, right, because I'm potassium sparing, I wanna make sure that my patient doesn't have a supplement that has potassium in it, because now that is going to shoot them up even higher. Contraindicated also if their potassium levels are greater than 5.5, because that's already high, and now I'm gonna greatly increase that as I put them on this because my potassium levels are going in, or increasing. And then remember, if they're pregnant, we weren't using any of these meds, we were gonna switch them to our LMNs, and then the stenosis, okay? Calcium channel blockers, we had 2, we had our DHPs and our non-DHP. Our DHP, we ended in peen, and then our non-DHP, we had verapamil and we had DILP. And then some of our high notes, remember edema, remember that our nifedipine was nasty, it caused my gingival enlargement. Your non-DHPs are gonna more so focus on the heart, whereas your DHPs are more so focused on the vasculature. But it doesn't mean that they don't have any properties to do both, right? But it's just that it's very negligible for them to cross. But your non-DHPs do have an effect on the vasculature and your blood pressure, whereas your DHPs are very heavily blood pressure, like don't expect to get any cardiac response out of those, not much. And then we already talked about the African American line, and then your contraindication in heart failure, and you're going to continue to hear this again. We'll talk about it in more detail, but just giving you your quick review. Pregnancy, we done beat this one. We got that. Our additional medications that we went over. So you have your alpha-2 blockers, which was the methodopa. Remembering that it was going to dry things up. It had those anticholinergic side effects. We had some confusion and craziness kind of going on when we talked about our methodopa. And then this was one of our meds that we used in pregnancy. Looking at, yes.
I just had a quick question about the pregnancy. So you change the med if they become pregnant, but if you have a patient who, let's say they're trying to get pregnant, would it be worth it to change their meds preemptively?
Yes.
Okay.
Yes. Because you don't want it in there since most people don't try or plan to like become pregnant, right? The people who plan to become pregnant are the people who struggle to become pregnant. The people who don't want to become pregnant are the people who get pregnant a lot easier. I'm serious. But yes, if they are trying and you know that they are trying, then it is awesome for you to go ahead and like take them off, but you need to check in with them to make sure that they are managed. These aren't typical like first line ones that we would want to put our patient on. So that's why you have to make sure and follow them closely to make sure that their blood pressure is managed with the ones that you do have them on.
Dragon.
Okay, but that's a great question. Looking at our beta blockers, so with this, lots of things, we just went over them, right? But make sure that you're tapering them off. The longer that they're on them, the higher the dose that they're on of a beta blocker, the more likely that you're going to have to taper them off. Okay, bradycardia, especially if you're adding it with another medication that is affecting the heart and slowing down that heart rate, you're more likely to see this bradycardia occur because now I have this drug A doing it, on top of my beta blocker doing it, and I'm gonna tank that person, okay? So you need to watch out for those meds and make sure that you're paying attention to that. Can I use a DHP with my beta blocker?
Yes.
A DHP calcium channel blocker?
Oh,
Yes.
Yes, my non-DHP I'm worried about, okay? Because that is working on the heart and now both of those things will be dropping together, all right? I'm not trying to be mean and tricky, like I'm just quickly quizzing y'all because this is what like your questions might look like. It's not as obvious, but they don't look like that. Sexual dysfunction, remember this is a big thing. We need to tell people so that they're aware of what's going on, tiredness, and then cautioning our patients who had diabetes because they were gonna mask that hypoglycemia, and then asthma because if they experience a lot of exacerbations that it could potentially cause an exacerbation in those patients. Beta-1 selective, non-selective, mixed, we talked about those, right? I mix my paint in the car, from a car in the lab. And then your ISAs, those are the ones that are good for your patients who experience a lot of bradycardia because they have that intrinsic sympathomimetic effect. Remember sympathomimetic or our sympathetic nervous system, right? Fight or flight. So if you have a patient who, when you keep putting them on their meds, they're dropping low, you can give them, or they're becoming bradycardic, you can give them one of these ISAs and it may not affect their heart rate as much. It's just gonna affect their blood pressure. It'll drop down that blood pressure and not really mess with their cardiac output as much, so you don't see the bradycardia. So that's the utility that we can see when we're looking at our ISAs. And that was our ACE pin. And then we'll see these as we continue to go over like heart failure, things like that. But your metoprolol, there's two different salts. You have that metoprolol can come in. You have metoprolol tartrate and you have metoprolol succinate. Your succinate is the one that you're going to use when we're talking about heart failure. So we'll go over it again, but just remember that because you can't use your tartrate for heart failure. You're using your succinate for your heart failure patients. Emergency, we talked about our esmolol. Migraines, we talked about propranolol. Pregnancy, we talked about the betalol. And then hydralazine is the one that we have with our vasodilator. This is typically going to be used with another medication. It's not very effective for us to use it by itself. And then some quick pearls. Make sure you're following up with your patient in that first month. Anytime you alter or you start any of your antihypertensive medications, review your mechanism of actions, review your adverse effects, review your contraindications, review the review that I put up. Combination pills, we like them because that helps with our adherence, right? So we're gonna check everything before we just increase a dose, before we say that this med doesn't work, right? I'm gonna make you tell me like, hey, are you, and then you can also double check the patient. Are they picking up their refills on time? And you can see when they pick up their stuff from us in the pharmacy. So you can just go back in there and be like, well, I gave you 30 days, but you went to the pharmacy 2 months ago. Like, where are you getting it from, if you're taking it? And they'll be like, oh yeah, I mean, like, I take it every other day. Okay, so you're not taking it out. So you also do your work before you add on. Start low, go slow. We don't want to overshoot. We don't want to cause that tiredness, the hypotension, all those other things. And then again, follow up, follow up, follow up, follow up. Any other slides after this is all FYI for you to look at. We're going to switch over to our other lecture for 10 minutes and then we'll take our 10-minute break and then come back. Any questions so far? Yes.
Can you just go back to the first image I saw?
Yes. This one.
Thank you.
Taking pictures. I'm gonna post it. I'll post it though. Alright, anything else right now? So don't forget, I'll have this posted as a quick review, but it's very similar to the full review that I put on there, like the 2-page review. It's similar to that as well. She's about to start. If you wanna download, we also put up the review for, what you're about to go over now as well. Take your notes on your slides or your paper, whatever you wanna do. But it's there for your reference. We're gonna set up real quick. Switch over.
Everyone, so today I'm Martha. I'll be going over diuretic medications. Here are the learning objectives for your reference. So first, let's go over some definitions. So diuretics are a group of drugs that cause the excretion of urine. And diuresis is what the excretion of that urine is called, and it's usually associated with large volumes. For tubular reabsorption means the transport of a substance from the nephron of your kidneys or the lumen into your bloodstream. For secretion, it's the transport of substances from the bloodstream into your nephron. And then for antidiuretic hormone, it's a hormone that regulates balance in the body by controlling water loss in the urine. A quick overview. So diuretics are a commonly prescribed group of medications used to treat several conditions. Can anyone name a few of these conditions that we'll see diuretics in?
Edema.
Yes, very good. So, heart failure, hypertension, and there's also ascites, which is just a condition associated with cirrhosis. The therapeutic effects of this class is to inhibit reabsorption of sodium, and so where sodium goes, water usually follows. So using this, we'll have increased urination, which leads to increased diuresis, drop in your blood pressure, and edema, because you're losing that water. And then this will also lead to decreased plasma volume. And so sometimes patients will come in and they'll say, oh, I'm on a water pill. This is what they're referring to as a diuretic. Right. Let's do a quick physiology review. So we have glomerular filtration rate. So this is the filtration of your blood into the kidneys through functional nephrons. And it usually indicates the best overall, like how well your kidneys are functioning. And it'll vary according to age, sex, and body size. Normal eGFR is about 130 milliliters per minute. For creatinine clearance, this is what we use to estimate GFR, and so we'll use something called the Cockcroft-Gault equation. I hope you've heard about it. But it usually, so since it's a estimate, it'll exceed the true GFR by 10 to 20%. Normal value is 90 to 140 milliliters per minute. Healthy young men will be about 125, and healthy young women will be about 115. And just as a side note, so creatinine clearance is the marker of creatinine leaving your body, and that's how they'll test it. So if you do have people with less muscle mass, which is where the creatinine comes from, the GFR will be different, and so it can either overestimate or be underestimated. And so also always taking in consideration, like, who are you treating, what do they look like, adjusting the doses based on the patient. Right, so here's the picture of a nephron, and nephrons also always want to conserve sodium. So there'll be a lot of areas where we'll see diuretics blocking the sodium to have the release of to keep it in your nephron so you have the excretion of water. So again, we have reabsorption. So from the lumen or the nephron back into the blood, 99% of sodium is filtered. Where sodium goes, water follows, and this is due to the osmotic gradient. And this will usually happen in the proximal convoluted tubule and the collecting ducts. We also have the collecting ducts under the influence of antidiuretic hormone. Tubular secretion is from the bloodstream back into the lumen. So you'll have the secretion of hydrogen resulting in acidic urine, and then organic acid and base secretory systems secrete weak acids and bases into the proximal convoluted tubule. And there's an example of a few weak acids and bases that are medications that filter into this acid and base secretory system. Here's the diagram of the nephron with where all the medications we're going to cover that are diuretics will affect the nephron, and diuretics will disrupt the nephron sodium reabsorption at various sites. And then some food for thought, the more distal segments usually compensate for the ones that are at the beginning. So you'll see compensation with the acetazolamide, number 1 at the proximal tubule, and then mannitol. And now for the proximal convoluted tubule, the carbonic anhydrase inhibitor diuretics will work here. This is where 60 to 70% of all sodium is reabsorbed. The organic acid and the base secretory system secretes waste products into the proximal convoluted tubule. And so the organic acid system is saturable. Can anyone tell me what saturable means?
It's like competitive, so it can be filled up.
So the saturable means like there's a limited number of spots along the nephron where drugs and substances can bind to. Once all of those transporters are filled up, it won't be able to filter the rest of them out, so they'll go straight through the rest of the kidney. And so when we have diuretics and loop and thiazide diuretic adverse effects, they'll be blocking those transporters and preventing the substances from being pushed back into your body or the bloodstream. And so one of these is uric acid. And so loop and thiazide diuretics will have an increased uric acid from being put into your nephrons, because it just blocks it so that it prevents the movement of substances. Yeah, I think, yeah.
So let's do your 10 minutes, and then you'll come back and we'll
Through the proximal convoluted tubule, we have the loop of Henle. For the descending loop of Henle, this is where water freely flows out and sodium is retained. This is mainly due because it's not permeable to sodium and there are no active transports. And this is where the osmotic diuretics will function. For the thick ascending limb of Henle, the cells are impermeable to water, but we do have active reabsorption of sodium, potassium, and chloride co-transporter. And here is where the loop diuretics will work. Basically, if you have trouble remembering it, once you're on a loop diuretic, and everything goes up from there. So, ascending loop of Henle. For the distal convoluted tubule, we have the thiazide diuretics. It's relatively impermeable to water. 10% of sodium is reabsorbed, and the calcium reabsorption is facilitated through a sodium-calcium exchanger into the interstitial fluid. And calcium is also regulated by parathyroid hormone. Next, we have the collecting ducts. So we'll have sodium channel blockers and the aldosterone antagonists work here, also known as the mineralocorticoid receptor antagonists. So aldosterone antagonists and mineralocorticoid receptor antagonists are the same thing. They're used interchangeably. We'll have principal cells here, and it's responsible for sodium, potassium, and water transport. It relies on the sodium-potassium ATPase pump, and K is exchanged for sodium. So the more sodium in the collecting ducts, the more the transporter will work to put the sodium into your body, and the more potassium that's lost. And this is what can cause the hypokalemia that you see. Hormonal influence in the collecting ducts, so we'll have aldosterone, which enhances sodium reabsorption and potassium and hydrogen excretion. And then we have antidiuretic hormone, which enhances water reabsorption. So far, are there any questions? Now we'll go into the pharmacology. For the clinical uses of diuretics, so we have edema, so the buildup of fluid in our arms and legs. Hypertension, which is increase of blood pressure. Hypercalcemia, which is increased calcium levels. Hypercalciuria with renal stones, so kidney stones, renal stones, they can be made out of calcium. So when you have high numbers of high concentration of calcium in your urine, it can cause and form renal stones. And you have glaucoma, so that's increased eye pressure. Mountain sickness, so this is increased elevations causes acid and base imbalance in our body, and we can use one of the diuretics for that. And then we have acute brain injuries, so we have inflammation and volume buildup in our brain. We can use a diuretic for that. And the drugs in parentheses are just drugs used for those conditions, but they're also listed later on in the slide deck. Next, we have some diuretic precautions. So digitalis or digoxin toxicity. So diuretic-induced hyperkalemia may precipitate this. And so digoxin actually inhibits the sodium-potassium pump in heart muscle. When you have decreased potassium, this means that digoxin is freely competing and can attach to those receptors and transporters more easily. And so when the digoxin binds, you'll have excessive inhibition, and this is what can lead to the digoxin toxicity. And so we'll monitor digoxin and the potassium levels when they're on this medication with loops, or not loops, but like diuretics in general. With lithium toxicity, we have diuretic-induced sodium losses. Our kidneys think that sodium and potassium are, or sodium and lithium are the same. And so because our body has lower sodium, the body will retain lithium more. And that leads to the toxicity. And then we also have hyperglycemia. So potassium is needed to move glucose across the cell. When potassium levels falls, less glucose moves across the cell and it'll remain in the plasma. And diuretic-induced hyperglycemia may be linked to potassium concentrations and ensure potassium levels will remain within, you want to ensure that potassium levels will remain within normal limits. Are there any questions on this slide? Next we have hyperuricemia. So as I mentioned before, there's competition in uric acid secretion in the organic acid secretory system. The direct effect of diuretics on promoting urate reabsorption by the proximal tubule, so it'll increase the urate reabsorption, and then since it's decreasing the blood volume in our body, it'll become more concentrated. And so this can lead to gout exacerbations, which is one of the complications of hyperuricemia. For allergic reactions, just watch out for them. Most of the diuretics have a sulfur or a sulfonamide, sulfonylureas, so the patient could get an allergic reaction to this sulfur. Use in patients with sulfonamide allergies is contraindicated per labeling, but there is like a 1% chance of them to get the cross-reactivity. They always want us to be very cautious though because of that 1% chance. So you could monitor them in the hospital if you need to give them something that's a diuretic that has the sulfur in it, since they're being very closely monitored. But outpatient, I would not recommend doing that because you don't have eyes on them and you don't know if they're going to have that reaction. Here's a summary chart of what we just went over for your review. So let's go into the drugs. So we have the carbonic anhydrase inhibitors. They are located and work on the proximal tubule of our nephron. It'll increase sodium and water excretion by inhibiting the enzyme carbonic anhydrase. It'll prevent the reabsorption of carbonic acid, which is the H2CO3. Because of this, we'll have less hydrogen being excreted into our lumen. The carbonic acid is also retained in the lumen because it can't turn into water and carbon dioxide, where they'll go back and keep making that cycle. And so the reason for the cycle is to bring in sodium into the cell, but since you don't have that mechanism going on anymore, you'll have the increased sodium excretion. And so with carbonic anhydrase inhibitors, you'll have this phenomenon called tachyphylaxis, and you'll have decreased efficacy after several days of therapy. And so this just happens because there's so many other mechanisms down the nephron that your kidneys will compensate for that extra excretion of sodium. Be like, oh, our body is excreting so much, let me bring it back in. And so that's why that happens.
So this is just a short-term med?
Yes. It is a short-term med. It's not usually used as a diuretic, and so its clinical uses is for open-angle glaucoma. So the eye drops, you'll put them in the eye, and they'll have that local effect. And so it'll just decrease the production of aqueous humor in the ciliary body of the eye. It's also used for mountain sickness greater than 10,000 feet. So you'll have a decrease of cerebral spinal fluid volume and pH, where carbonic acid is responsible for secreting the bicarb. And so the mild acidosis results in the hyperventilation. And so you'll give this to them in the short term so that they can recover while they're up at higher elevation. And so you'll have that's just how you would dose it. So take nightly for 5 days before ascent to prevent weakness, breathlessness, dizziness, nausea, and cerebral pulmonary edema. Right. So just FYI, you won't need to know it. So pharmacokinetically, it's absorbed well orally. It's not metabolized in the body, but it's excreted by the proximal convoluted tubule and used there. Are there any questions? Some adverse effects that we'll see can affect the CNS, so drowsiness, anorexia, headache, and depression. You'll also see the allergic reaction which is usually a rash, so that's due to the sulfonamide derivative contained in the medication. It will cause the low potassium, and it'll cause hyperchloremic metabolic acidosis. It also causes an increase of kidney stones in your body because calcium is less soluble in an alkaline environment, and so it increases the risk tenfold. For monitoring, we'll have urinary alkalosis, pH increases excretion of weak acids, and decreases excretions of weak bases. And so it can also monitor them for metabolic acidosis, which is mild medication. Next, the contraindications. So you don't want to use this in cirrhosis or liver damage because acidosis might increase the ammonia retention, which leads to hepatic encephalopathy. You also want to caution in patients with COPD and those with respiratory acidosis. And some drug interactions, so it might increase cyclosporin through drug concentrations resulting in nephrotoxicity and neurotoxicity. So the drugs we find in this class are acetazolamide, which is called Diamox. You do not need to know the dosage form and the dose, but it's there for reference. We want to give this medication on alternate days or 2 days, and then you'll skip a day. And that's basically because of the tachyphylaxis or the fact that it doesn't work later on. So we're just trying to mitigate that risk a little, or that phenomenon a little bit. For the different formulation of acetazolamide, so the Diamox equals, it's used for adjunctive treatment of open-angle glaucoma, preoperatively in acute angle closure glaucoma, and it's used to lower intraocular pressure or IOP. And then you want to prevent, it's used for the prevention or amelioration or improvement of acute mountain sickness, like we discussed earlier. And then another drug in this class is methazolamide as well. There are moderate efficacy due to compensation of the nephrons in the distal segments, compensating for the reduced sodium, so the tachyphylaxis. And then we also have the eye drops, so dorzolamide and brinzolamide are ophthalmic CIA, carbonic anhydrase inhibitors used to treat open-angle glaucoma. Are there any questions about this drug class? Right, next we have osmotic diuretics. So these occur in the descending loop of Henle. The picture is a little bit off, so if you want to just move that over a little bit. We have increases of plasma volume delivered to the kidneys, increasing urinary output due to hypertonic plasma, which draws fluid out of the tissues and promotes water diuresis. So this is putting water from, like, between your cells, out of your, in the brain, into your vasculature or your bloodstream. And so it's and also, yeah, pulling it into the nephron through the descending loop of Henle. And so it's an osmotic active agent. It's largely confined to the extracellular space. It's metabolically inert in humans, so it doesn't really get broken down into anything. Next we have the osmotic diuretics, we've been talking about that, sorry. So the reduction of intracranial pressure and the treatment of cerebral edema by reducing brain volume. And then it maintains urine flow. So if there's acute toxic congestion of substances, it'll be able to treat that And then we have to give this medication IV because it has horrible oral absorption when it's given by mouth. And then some adverse effects, so increased intravascular pressure, that will exacerbate chronic heart failure since you have more fluid in your blood vessels and it's causing more work for your heart. And then hypernatremia due to the dehydration from fluid loss. Some contraindications, so if they have active intracranial bleeding, since it can work in your brain, you don't want to cause less blood flow there and exacerbate their bleeding or clot. If they have pulmonary edema or chronic edema due to cardio insufficiency, so if they have like chronic heart failure, don't want to use this. And then monitor their kidney functions, their electrolytes, their intracranial pressure, and their hydration status. And the drug in this class is mannitol or osmotrol, which it's kept in the refrigerator, so the product may crystallize and require warming up before you give the injection to them. So put in a hot water bath, dry heat oven, cool it down so that that doesn't occur. Are there any questions so far for this drug class?
Excuse me, man.
Yes.
Is there, it's kind of a random question. Is there a max systolic that you'd be worried about hitting with mannitol that you have to titrate to?
That is a great question. He asked if there's a max.
The warning, like a limit, upper limit?
Upper limit for what,
For
like
mannitol,
running it?
you like titrate to a certain systolic until it becomes an issue.
So depending on the indication or what you're, yes. So you're always gonna have,
Patient presentation.
yes, and so typically whenever you're looking at stuff, these people are in the hospital. And so this is something that we can like turn on and turn off, but you have to make sure that it doesn't cool. Sometimes next to the bedside, you'll see like where we have it wrapped in like something to keep it warm so that it doesn't crystallize and stuff. So sometimes with this one, it's like how are they presenting? Do I need to have it on right now? Take it off? Like we'll bring several bags of this from the pharmacy. So yes, and it can vary depending on what pressures you're getting, and a lot of them will have like a bolt in their head measuring their pressures. So that's something that like it fluctuates
Just
a lot.
kind of counterintuitive in some ways. It's like you don't want to create ICP, but you're kind of creating ICP.
Yes. Yes.
Alright.
Yes.
Alright.
And it's a drug that we don't love in the pharmacy at all, or when y'all are administering it because
We
if
just
it
have to
cools
know.
down. Yeah.
Okay.
Yeah. Sorry.
You're good. Thank you.
Now we have a loop diuretic, so it'll selectively block reabsorption of sodium and chloride in the ascending loop of Henle, as well as potassium. We can see in the diagram that it will affect that sodium, potassium, and chloride pump. And in doing so, it will also increase the calcium content in the urine. So another effect of loop diuretics is that it can also increase renal blood flow, and this is because loop diuretics actually increase prostaglandin synthesis, and prostaglandins can increase vasodilation in the kidneys, and so that's how it's increasing the blood flow. It is the most efficacious diuretic class. It will work well in a variety of patients regardless of renal function, and it also has a high ceiling, so high doses increase efficacy with each dose. And it also has a rapid onset. So just a side note, many of these diuretics will start working within a few minutes. And so something to make sure to tell the patient is that they take it in the morning, because then they'll be able to go to the bathroom during the day. If they take it during the night, then they'll have to keep getting up to go to the bathroom, and that can affect their sleep quality. So just something to keep in mind. And then next we have the clinical uses of loop diuretics. So we have the acute pulmonary edema or other edematous conditions. It's the drug of choice for reducing the extracellular volume in heart failure and other conditions. For acute renal function or renal failure, it can increase the rate of flow to the urine and enhance potassium excretion. Can cause hyperkalemia, enhance urinary excretion of potassium. I think that should be hypokalemia, so if you could change that on your slides for me, please. And then acute hypercalcemia, so it'll, oh, just kidding, I'm sorry. So if they have high potassium, it's going to fix that by causing the excretion of potassium into their urine. Sorry about that, but there you go. And then acute hypercalcemia, so it'll cause tubular excretion of calcium into the urine. There we go. And here we are, the adverse effects. So yes, it causes hypokalemia and hypocalcemia. Can also cause hypomagnesemia. Chronic use of loop diuretics combined with a low dietary intake of magnesium. And as stated before, so it competes with urate for that transporter. So you'll get hyperuricemia, which can lead to gout exacerbation. And we'll see this with ethacrynic acid and furosemide. For acute hypovolemia, this can lead to hypotension, so monitoring them when they first start loop diuretics, and ototoxicity, so it can cause ear damage, ear toxicity, and cause that permanent tinnitus and deafness with high doses at peak concentration. And you'll see this the most with ethacrynic acid, and then next is furosemide, then bumetanide, and then torsemide. Some contraindications include the hypersensitivity to that sulfonamide, except for ethacrynic acid. That is the only loop diuretic that does not have the sulfur group in it, so they should not have a problem if they are allergic to that. And then we also have anuric patients or patients with severe electrolyte disturbances. Some drug interactions, so nephrotoxic agents, things that can accumulate in the kidneys, and then NSAIDs. So NSAIDs or non-steroidal anti-inflammatory drugs, they inhibit prostaglandin synthesis because prostaglandins can also cause inflammation. So by doing this, it's directly affecting what loop diuretics do when they increase prostaglandin synthesis, and so they're just canceling each other out. And NSAIDs can actually cause sodium and water retention. So for monitoring, we want to monitor their kidney function, their electrolytes, also monitor their blood pressure due to the acute hypovolemia, which leads to hypotension. And then we also want to look at their weight. So usually patients, if they come into the hospital, they'll have a dry weight and then their weight right now. So dry weight means what they're usually at without any of their edema and the weight that they're at right now, so they might be experiencing some edema. And so if they keep going up with their edema and their weight, then that probably means that you need to increase the dose of their diuretics, because it's not helping them right now. And then checking their hydration status and checking their hearing, so having a baseline hearing. And then there are some symptoms of fluid and electrolyte disturbances, so the dry mouth, thirst, weakness, lethargy, to name a few, and then you can see the rest of them there. So the medications in this class, we have bumetanide or Bumix. It has a 1-to-1 oral IV ratio, and it's the most potent loop diuretic. So you'll see this at low doses. For furosemide, its brand name is Lasix, and so Lasix is a name derived from last 6 hours. It's usually given twice a day or BID for hypertension due to the short half-life. And then both furosemide and ethacrynic acid are more likely to cause hyperuricemia and then compete with the uric acid for secretion. And important to note here is the oral to IV ratio. So furosemide is not very good at oral absorption, and so going from IV to oral, you have to multiply by 2. And next we have torsemide, so that's Demodex. It's a 1-to-1 ratio, and it's moderately potent loop diuretic. And then lastly, we have ethacrynic acid. It's not a sulfonamide derivative. It's a potential option, like I said, for people with sulfa allergy. However, it's not used very often because of the adverse effects are more severe than the other ones for this class, drug. Are there any questions so far over loop diuretics? Next we have the thiazide and thiazide-like diuretics. So these work in the distal convoluted tubule. They will inhibit sodium and chloride reabsorption, and it will result in water retention in the tubule and later excretion. Continued use will eventually normalize the volume through reduced peripheral resistance, and then it will drive lower blood pressure. So the increased excretion of sodium and chloride, have the loss of potassium, because this is where potassium is exchanged for the sodium, and so we'll have the continual loss of sodium in the body. And then we'll have, from the body, yeah, and then we'll have loss of magnesium, which occur with the chronic use of thiazide diuretics, usually in the elderly. You'll have decreased urinary calcium excretion. So decreased calcium content in the urine, promoting the reabsorption of calcium in the distal convoluted tubule. And then we will have the reduced peripheral vascular resistance, so relaxation of arterial smooth muscle. And so for the clinical uses, it's used for hypertension, heart failure, so the edema is associated with heart failure, and then hypercalciuria, nephrolithiasis, or just a fancy name for kidney stones. And so since thiazides block calcium from going into the lumen or your urine, you have less calcium there and less potential for kidney stones to form. Next we have the pharmacokinetics. So the onset is immediate. You'll have the diuresis, and then 1 to 3 weeks you'll have the antihypertensive effect of it. Renally, it's not effective in patients with inadequate kidney function. You'll have if they have a creatinine clearance less than 30 milliliters per minute and a serum creatinine greater than 2.5. And metolazone remains effective for EGFR of 10 to 20 milliliters per minute, probably because they studied it in the patient with those population of the 10 to 20, and there's not much data for the other thiazides in that kidney function range. Next, we have the adverse effects, so hypokalemia, hyponatremia, and the hyperuricemia. And so for the hyponatremia portion, you want to limit water intake, basically because there won't be intaking sodium with it, or you make sure they're intaking sodium, but Next we have the hyperglycemia effect, so it'll impair release of insulin and tissue uptake of glucose. And so diabetes patients may have difficulty maintaining appropriate blood sugar levels. For hypercalcemia, it'll inhibit the secretion of calcium, which can lead to elevated serum calcium levels, right? Volume depletion. So making sure that you're asking the patient if they're having any orthostatic hypotension or lightheadedness when they get up from sitting or laying down to sitting to standing. And then a hypersensitivity reaction. Thiazides have that sulfur group, so monitoring them to make sure they don't have a reaction. Okay, so we want to monitor their kidney function, their electrolytes, and their blood pressure. And then we have the drug interactions. So we did have that wonderful question earlier about ACE inhibitors and if we can use thiazides at the same time. It can cause hypotension if started aggressively. So usually it's recommended that you start the ACE, have their blood pressure stabilize just a little bit, and then you can start the thiazide. That's what's, I think, recommended more, but what she was saying, like, just if they're stage 1 hypertension, then you need to monitor them more closely. This one has the digoxin toxicity, the lithium drug interaction, and the non-steroidal anti-inflammatory drugs. So thiazides also create some prostaglandins indirectly, and that could interact with that synthesis. Some drugs in this class, so we have thiazide, so hydrochlorothiazide and chlorothiazide, they both have thiazide in their names. Hydrochlorothiazide is the most commonly used agent in the class. You can get up to doses of 200 used in edema, but it's not really tested on, just FYI. Chlorothiazide is the only thiazide available as an injection. And then we have the thiazide-like, so we have chlorthalidone, which is diuretic with most evidence for improved cardiovascular outcomes. There is little benefit in blood pressure reduction. And then the half-life of 50 to 60 hours provides 24-hour blood pressure control. We also have indapamide, which is Losol, number 1 in the class. And we have metolazone, like I said before, it can be used for the GFR in patients with GFR of 10 to 20 milliliters per minute. Are there any questions for the thiazide class? Next we have the potassium-sparing diuretics, so the mineralocorticoid receptor antagonists and or also called the aldosterone antagonists. So agents in this class include eplerenone, spironolactone, and finerenone. It blocks the effects of aldosterone in the collecting duct, leading to sodium loss and potassium retention. And then aldosterone can contribute to cardiac hypertrophy and myocardial fibrosis. For the sodium channel inhibitors, we have amiloride and triamterene. The mechanism is it has increased excretion of sodium and potassium retention in the collecting duct, and it does not work on aldosterone. So some clinical uses, so it's used as the diuretic. It's used in heart failure to help with edema. Secondary hyperaldosteronism, we have spironolactone that's more effective in patients with hepatic cirrhosis and nephrotic syndrome. Then we have ascites, which is the condition associated with cirrhosis that can occur. And then we have polycystic ovary syndrome, which is blocking androgen receptors, inhibiting steroid synthesis at high doses. So adverse effects, we can have hyperkalemia, we can have kidney stones, and then we can also have gynecomastia and impotence and menstrual irregularities. This is most seen with spironolactone because it's the most steroid-like of the potassium-sparing diuretics. And so we'll use eplerenone instead to mitigate this risk. And then it's contraindicated in active peptic ulcer disease and pregnancy. Monitoring, we want to monitor their renal function and their electrolytes. For the pharmacokinetics, the spironolactone is a potent inhibitor of the P-glycoprotein, and eplerenone is metabolized by CYP3A4. So drug interactions, so you want to make sure that the patient isn't taking any potassium supplements. Make sure that you monitor them if they're on an ACE or an ARB, since we know those are hyperkalemic or potassium-sparing drugs. And then we have caution with CYP3A4 drug interactions when you're using eplerenone. So we have sodium channel blockers, amiloride, and triamterene. So triamterene is the drug of choice for lithium-induced nephrogenic diabetes insipidus. For the MRAs, we have eplerenone, which reduces mortality and morbidity associated with heart failure. Avoid use if they have poor renal function, so serum creatinine greater than 2 or 1.8, or a creatinine clearance less than 50. And this is the same thing with spironolactone. So those two drugs, check their renal function before prescribing it. For finerenone, it's a non-steroidal mineralocorticoid receptor antagonist. It'll reduce the risk of sustained eGFR decline, patients with end-stage kidney disease, and then CV death in those with CKD and type 2 diabetes. So the learning objectives here, what are some key takeaways? So Major Heart did post a study guide. If you look at that, can't see my screen. There we go. So she will post it, or it is posted, and it's just focusing on what drugs are in the class, what adverse effects to look at, their mechanism of action, where they work. And so this is and again, like she said earlier, it's a study guide. Not all the questions may come from here, but just something to help you get started. What questions do you all have? You guys done with the PowerPoint? I think Major Heart was the plan.